ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday.
So good evening, everyone. I am Pallavi from Olympic Pharmaceutical. Welcome you all for this exclusive webinar series from Endometriosis Society India, particularly on the topic endometriosis. So this webinar series consists of 12 sessions, and today we are having the 11th session of the series. And the best part of this series, in every session, every module, we are getting 2 credit points for the participant. So today we are having a chairperson, Dr. Mohana Pramila and Dr. Ramni Devi. So I will introduce Dr. Mohana Pramila. So Dr. Mohana Pramila is a consultant ops and fertility physician, laparoscopic surgeon. She is a medical director at Sri Narayan Medical Center, Ambattur. She has done her MBBS from Tanjavur Medical College and the MD DGO from the Madras College, Madras Medical College, Chennai. And she has also done her ART training at the NUH, Singapore. Dr.
Dr. Pallavi, yes.
Yeah. So,
And I was trained. One more thing I wanted to add. Proudly, I will say I was trained under Dr. Ramani Devi. She is my sole inspiration.
yeah, ma'am is a core architecture of this entire program. So yes, I welcome you all for this wonderful module today. So over to Dr. Mohana and Dr. Ramni ma'am.
Sir, will you talk first, sir? Pradeep, sir?
Yeah, okay.
Okay, sir. Okay. So now I have the proud privilege of introducing Dr. Pradeep K. Mitra, sir, who is the founder secretary general of Endometriosis Society of India, and currently he is the president of Endo Society India. And he was the past president of Bengal OBGYN Society. He is working on endometriosis and adenomyosis for at least for the past more than 20 years. He is an organizing secretary for ICE conference at 2025, which was an international conference on endometriosis. He has more than 17 journal publications in journals and number of books, and he's been an international faculty in FIGO, YES, AOCOG, SUD conference, TNFOG, etc. Past faculty of University of Illinois, Chicago, USA, and past faculty Uchida Hospital, Japan, and he is visiting an experimental endometriosis research fellow in UBC, Canada, and he is also a principal investigator in NHS South Health Foundation, UK. So with this, I'll be happy to say that he will be talking on obstetric complications, what we face in patients who had been treated with endometriosis. Because endometriosis doesn't stop with just the patient becoming pregnant, but it becomes a very high risk pregnancy where the patient needs continuous monitoring throughout the pregnancy. So let us hear to his talk on this particular important topic. Thank you, sir.
Thank you, Dr. Ramani, for kind introduction and kind words. Definitely, I will try to do justice to my topic. I share my slides. I'm sharing the slides. Vignesh.
Sir, it's not visible yet. Please try to share again.
Vignesh.
Sir, you can share again.
Yeah. Just sharing it is not coming. Let me check it.
Sir, click on a share button below.
Stand थोड़ा
I think sir,
stand.
there is an internet issue.
Let me. Yeah.
Indra, madam, please mute yourself.
No, the issue is not there. Window. Entire screen window. It should come on a window, isn't it?
Not in window, entire screen.
Entire screen. Okay.
Yes, and share.
Sure, I've just shared it. Yes, right now. I don't think no, it's not coming. Entire screen in window, I think.
Try to share,
So there
sir.
right now, na? Is it? I just.
Sir, you did perfectly good previous time. Just follow that step.
Okay, right. Yeah.
And share.
Yeah. Now.
Blue button
Have you
share.
seen,
It's not sharing currently.
blue button?
First, select the screen button, share button in middle. Then select whatever your option you choose. Entire screen, window, anything. And then click share.
This share. That one is not filling. It is some kind of auto share system. Yeah. Okay. I think it's clear. Dinesh?
Yes, sir, it's coming. Just wait. Yes, sir, it's came. Sir, you are in mute. Please unmute. Pradeep sir, you are in a mute. Yes, sir. You are in a mute.
Huh.
Now we can
Okay.
see you. You can start again.
Okay. Okay. Thank you. Thank you very much. Now, these two sentences, you cannot become pregnant if you have endometriosis. And the second one, if you become pregnant, it will cure endometriosis. And none of the sentence statements are true in our real life. Why? We have to understand the four risk factors. One, the increased risk of pelvic pain in endo, increased risk of fertility, increased risk of miscarriage, and higher risk of various complications. And of course, there might be asymptomatic endometriosis in 50% cases, of which most of us are sometimes unaware of. Types of management, what is being done, the cases of adenomyosis is associated with pelvic endometriosis, and 10% cases of fibroids of any CO grade might be there. Adenomyosis is detected in adolescent and post-adolescent endometriosis as well, and most of the pelvic endometriosis cases might have small adeno or the twinning of endometriosis. And why subfertility occurs in adeno complex? Everywhere or every place it is being researched, and so many quality factors are coming out, but not about the pregnancy outcome. And our management is to reach the Rome. That is, all road leads to Rome to have a successful conception. Now, why this topic is so special to me? Because we often try to enjoy when pregnancy become positive and forget to follow the outcome. And my personal obstetric experience has seen quite a few mishaps, but didn't know why that happened. And now that I understand its importance, after going through various literatures for the last 5 years or so, this is a uh, review of literature and two important and in this study, the three steps are followed. First is identification, then followed by screening, and then one in third is circumcision. Made. Now, why this aromatic part is important along with endo? There are six basic factors. Number one is resistance to selective effect of progesterone, landing up with the dysregulation of endometrial FOXA, IGF2, and glycodaline. Secondly, is the formation of adhesion. It's so important. And third one is, of course, inflammatory triggering at endometrial and systemic level, which is equally important at the moment. Then uterine contraction, more frequent with greater tone and wider extent. Fourthly, or fifth point is increased expression of various enzymes, particularly those related to reactive oxygen species. And lastly, thickening of the junctional zone. If you just have a look to this particular area that is on the left side, you see the causes of infertility in endometriosis due to pelvic adhesion, or rather subfertility. Factors which are involved here in pelvic endo is pelvic adhesion, pelvic inflammation, and immune cell treatment, well, increased ovarian and potential peritoneal fibrosis, and increased peripheral vascular stiffness. On the right hand side, the adenomyotic part has been shown, and here hyperperistalsis, increased uterine fibrosis, uterine inflammation, abnormal uterine contractility, abnormal endothelial function, and abnormal concentration, which are becoming part immune. So if you combine both of them in the endoadrenal complex, as I highlighted, both of them uh, remain together in most of the cases. This becomes a picture and not detailing in a deeper dive. Uh, so conservative treatment, whatever we do, that minimizes but cannot eliminate the pre-existing factors like chronic inflammation, uterine hyperperistalsis, oxidative stress, uh, and role of peritoneal macrophages is so important. And of course, follicle genesis is not as such impaired with isolated adenomyosis. However, in post-consequence pathogenesis, when there are two areas, as I said, adenomyosis with or without endometriosis, it is easier to explain. Uh, it is one area is abnormal presentation, uterine oxidative space. Endometrium leads to abnormal microenvironment, local area leading to abnormal presentation. I will come to that later. And second part is abnormal uterine contractility in the form of hyperperistalsis, dysperistalsis, particularly in the luteal phase and onwards. When it is endometriosis alone, it is little difficult to explain. However, some factors are so important. One is fibrotic entrapment of the pelvic vessels. Secondly, numerous molecular abnormalities are noted, and it increase in junction zone, chronic inflammatory gangrene, and there might be impact on superficial ioma and DIE, and isolated endometriosis abnormal ovum might be the sole cause. Now there are two areas, but a smaller area of course, but I'll be taking up this part first because it is also equally important. In pregnancy, we have seen there is reduction of the symptoms, which is absolutely apparent, and why reduced prostaglandin, various cytokines, and temporary decidulation of endometriosis. In ioma or sometimes we see intracellular variations which are misleading for cancerous condition, but it is known as ovarian rupture occurs and ovarian abscess with spontaneous peritoneum pregnancy, but is known as sheep. It is rare but life
Sir, Pratik sir, you are not audible. You are not audible.
So that's the internet issue, ma'am.
Sir, you are not audible, sir. Pratik sir. You are not audible.
Is it possible to call him smart?
Yes.
Hello?
Yes, now it is audible, sir. Now it is audible. Go ahead, sir.
From where I had missed it.
Yeah, you go back to the
Can you see the slide?
Spontaneous,
slides.
Okay.
Previously,
spontaneous hemoperitoneum.
chemoperitoneum. Go to that slide. Go back. Madam, நீங்க எப்ப join பண்றீங்க?
I think from here I can. Okay, can you hear me now? Hello?
Is
Hello?
audible, sir?
Hello?
Sir, now you are audible,
May I
sir.
go ahead?
Sir, you are audible. Yes, sir, you are audible.
Hello?
Yes, sir, you can go ahead.
Is it? Okay, okay.
Hmm.
So I have shown the review of literature of the last 5 years where Prisma and Armstead studies have been done, and there are three stages like identification followed by screening and then a or inferences had been made. Now, I felt that my had more impact than in the metropolis so far pregnancy outcomes are concerned, and this is due to six progesterone, resulting in dysregulation of endometrial FOXA or IGF2 or glycodyline. Second one is formation of adhesion. Third one is inflammatory triggering at endometrial and systemic level. Fourth one, uterine contraction, which is more frequent, with wider than increased release of the active oxygen species. And last one is, of course, thickening of the junction zones. So if you have looked at this slide, basic factors of fertility have been shown, infertility and endometriosis. There are 4 or 5 areas to be looked into. One is pelvic adhesion, then pelvic inflammation and immune cell recruitment, increased ovarian and peritoneal fibrosis, and increased peripheral vascular stiffness. Another eye hyperperistalsis and increased uterine fibrosis, uterine inflammation, abnormal uterine contractility, abnormal epithelial or endothelial functions, and abnormal placentation. These are the factors. But when you combine both of them, the scenario becomes more grave. And these are the deeper dive I'm not detailing. Conservative treatment of any form minimize but cannot eliminate the pre-existing causative factors like uterine hyperperistalsis, chronic inflammation and fibrosis, abnormal vasculature, steroid metabolism, peritoneal macrophages play a crucial role, and folliculogenesis as such not impaired in isolated anomalies. When both are combined, it is easier to explain because of two factors. One is uh, hello, hello, abnormal presentation and abnormal uterine contractility, hyperperistalsis, dysperistalsis in the luteal phase onwards. But when it endometriosis is alone, 3 or 4 factors are there. One is fibrotic entrapment of the pelvic vessels, numerous endometrial molecular abnormalities, chronic inflammatory pelvic environment. There might be impact of endometrioma or implants or depletion, and abnormal ovum might be the sole cause. Before going to the depth, I would like to divide the two areas. One is the effects of pregnancy on endometriosis. This is although small, but I think it is uh, important to highlight some of the basic things. We have seen the symptoms apparently when pregnancy occurs, and higher progesterone levels, reduced prostaglandins and cytokines. In neoma, we often sometimes see intercystic vegetation, which often misleading may just point towards malignancy, but it is not that. This is due to acidiosis. And rarely ovarian rupture might occur in the first trimester, and sometimes see the ovarian abscess. Then spontaneous hemophilia in pregnancy is another life-threatening complication, usually occurs in the second trimester or immediately after delivery, and end up with severe abdominal pain, hemorrhagic shock, and fetal distress. It's caused by spontaneous rupture of endometrial foci and bowel tissue of chronic inflammation due to increased tension from adhesion with concomitant entrapment of vascular matrix. Deep lesion in the posterior compartment. I have seen 1 or 2 cases in the lung. The second one is a pneumothorax or pneumothorax, which is also a potentially life-saving condition unless suspected promptly, and it is due to the rupture of the adhesion between endometriotic foci and the diaphragm, with the landing up of pneumothorax immediately, and in future or later that might lead to formation of fibrothorax and diminish the expansion of the lung. Then another one is a silent bowel perforation leading to peritonitis. It is also a very serious complication. It is often detected when peritonitis is already developed. So it is occurs due to destabilization in pregnancy, which results in transmural reduction of size and reduction of the mural thickness of intestine. It has been noted in the second trimester of pregnancy or shortly after childbirth, and this might happen in sigmoid, rectum, appendix, and ileum and cecum. That has also been noted, and Dr. Mandar has one of my friends. He reported this one case, and appendicular endometriosis is commonly all of us have seen it, and 2.8% cases in general, and appendicitis might also occur in pregnancy condition. Then bladder rupture leading to automatic uroperitoneum, which is rare but sometimes happen, and which land up with premature labor, and most patients with bladder endometriosis have been successfully treated without adverse effects on the pregnancy outcome. But it is one of the conditions. Then let me pass on to the other important or greater area, that is the effect of endoadenocomplex on obstetric outcome. Normally, or when in non-endometriotic pregnancy, the endometrial mesenchymal stem progenitor cell, that is ENSC, which increases the endometrial stromal fibroblast, that is EFSS, and with the effect of progesterone that result in fasciculation. This is the basic fact. But what happens in endometriosis? This endometrial stromal fibroblast cannot go properly or proceed properly due to progesterone resistance, and that leads to impaired vascularization, and that along with junctional zone abnormalities may land up with so many problems. Now, abnormal placentation is a key area, and it has got impact on the two sides. One side, the fetus and the mother, and on the other side, the placenta and cord issues, cord-related areas or problems. The first problem is miscarriage, which there are three types. Number one is the peri-implantation miscarriage, where Hoxa 10 and 11 dysregulation along with reduction of anti-angiogenic and increasing VEGF, etc., all lead to abnormal angiogenesis, which increases the abnormal phenotypes impairment, which is the main area. So for receptivity of the fertilized ovum concerned at four levels, that is adhesion, apposition, adhesion, penetration followed by adhesion, which is the thought of late Professor D. Chakraborty, my mentor in various areas. And in ERT, pituitary downregulation results in diminution, increase of estrogen, and there is increasing restorement of growth of adenomyosis, etc. The second is post-implantation miscarriage, where this abnormal presentation cascade uh, might be the cause, and recurrent miscarriage is the other area. Then, ART and pregnancy. We have seen that clinical pregnancy rate of ART in patients without or with abnormalities is not much different as far as percentage is concerned, like 41% with abnormalities and 49% in with normal patients. When comes the question of miscarriage, there is drastic increase in the number of abortion and miscarriage in adenomatic patients, which is about 32%. In contrast, it is only 14% when it happens to be in non-adenomatic patients. Then second form is premature rupture of membrane or preterm birth, a cascade of adenocomplex. There is reduction of the normal transformation of the spiral artery in the junctional zone, which leads to increasing placental hypohydration, resulting in pro-inflammatory mediated increase like prostaglandin MMPs, bad interleukin, which land up with local and systemic inflammation, which results in abnormally and finally the onset of labor. So ovarian endometriosis plus ART might be the cause of twofold increase of this PRON and uterine wall thickness uh, in second trimester. We sometimes can predict the chance of preterm labor. Of course, the coincidental factors should be considered like maternal age, smoking status, primiparity, existence of fibroids or endometriosis, and BMI before pregnancy. These are the relevant evidence. I am not detailing them. Then third one is ectopic pregnancy and all the sites of probable ectopic pregnancy. uh, This might occur and it is around 6 times in adenomyosis and it can be found in infundibular region or ampullary region, ischic region, even inside the uterine valve that is intramural pregnancy and here is one such case uh, which uh, I had noted in the last. Then small for date gestation, the fourth one. There are four reasons. One is the premature residual aging. Second one is blood flow. Blood flow. See, in pneumocystis, a lot of blood flows inside the adenomatic lesion, but the list is there in the placenta. So placenta is having less vascular supply. And third point is chronic inflammatory processes, which I have highlighted many times. And fourth one, progesterone resistance may itself leads to small cord so fetal ghost restriction when adenomasis is there and placental insufficiency is a key factor which results in symmetrical or asymmetrical IEG till date and the live birth rate. We have seen there is 12% reduction of the live birth rate when this endoadrenal complex, particularly adenomasis, is there. Then preeclampsia, pregnancy-induced hypertension, and preeclampsia. Several factors are considered. One is a shallow trophoblastic invasion into the maternal residua. Secondly, spiral arteriolar abnormality. Third is defective placentation. And fourth one, this is also molecular level. It's important that is abnormal soluble FNS like tyrosine kinase, which is known as in short SFLT1. And the fourth one is inhibition of the pro-angiogenic factor. But several contradictions are there in endometriosis and adenomyosis. The VEGF is increased to share. As such, there may be neovascularization. So people say that there should be reduction of preeclamptic toxemia or preeclampsia or PIH. But anyway, these are all controversial issues. Yes, in for and against many points and many things are there in the literature. Then gestational diabetes, acceleration of adenomyosis has been reported in few journals of literature, but that is also conflicting whether that as such occurs due to adenocomplex or endometriosis or not. Then, very important part is placenta, previa, abductive placenta, and morbid placenta. We do not know whether it is the accretion or the cause. Why? Because in DIE or depletion because of the adenomasis, there is positional resistance and abnormal uterine contraction, which leads to delayed implantation beyond the window period of receptivity. And in some reports, frozen embryo transfer might help in this process, and that all leads to embryo misplacement, resulting in placenta previa and or accreta, that is placenta spectrum. The hypothesis of a causal relationship between depletion and placenta previa could be defined as probable strong evidence. Malpresentation is another area. In adenomyosis, it has been shown that it might be associated with increased risk of fetal malpresentation, particularly breach of transverse life during pregnancy. Why? Because the ectopic endometrial tissue causes uterine enlargement. structural abnormality, reduction in the severe cascaders, as we have said, with or without fibroid, and restricting the fetus's ability to turn into proper head down position, and often leading to high rates of cesarean delivery. Then mode of delivery. Cesarean section is the common procedure. Why? Because it comes as a basic indication in this particular area of endometrial complex, as it might be one of the highly valuable pregnancy with or without various obstetric complications, as I have highlighted, and hygienic risk of vaginal delivery. But CS has its own complication. You all know. I am not going to that. Vis-a-vis the vaginal delivery, often it will end up with instrumental delivery, leading to vulvovaginal or perineal laceration, particularly if it is associated with deep infiltrating endometriosis in the posterior compartment. So, safe cesarean section is the means of the by skilled surgery team when you go ahead with pregnancy in these conditions. So, you should look for more controlled alternatives to ensure optimum maternal and fetal postpartum hemorrhage any type, and various reports there in group 1 as such in adenovirus is the chance of PPH after cesarean or normal delivery within first 24 hours occurred. This is reported by Healy and his colleagues. And then in abnormal postpartum uterine contraction due to fixation of the uterus, uh, either adhesion, PID, or deep lesion, this might occur. And in grade 3, some identifiable factors have been noted, but what is the extent and what is the exact nature, particularly in the junctional zone, which might predispose to BPH, is not being cleared up at the moment. Then silent rupture of the uterus. The facts and figures are like this. In adenomyosis with a damaged uterus, which is significantly associated with placenta accreta spectrum or placenta previa, and the rupture is mostly silent and often located in the posterior uterine wall. In contrast, since the spontaneous rupture is much higher after adenomyotomy, like 6% as compared to 0.26 after myomectomy, so this chance is becoming more in this scarred uterus, and chance of rupture in non-scarred uterus is approximately 0.005% as compared to scarred uterus, which as such varies from 0.27 to 0.7%. Then DIC is another area. Usually, the few cases have been reported after suction curettage, particularly complete abortion in aromatic patients. Uh, DIC has been reported. Factors like bleeding, tissue necrosis might be seen in rarely. Patient, the likelihood of neonatal intensive care unit admission increased in two meta-analyses found in the literature, and findings of the score uh, is usually less than 7, and which have been noted in one meta-analysis, which rarely may end up with neonatal death. So obstetric outcome in two areas, one is surgery and other area is DRT, either IC or ET. In surgery, procedure results in reduction of the total uterine volume. There is removal of large part of the myometrium, particularly in adenomyotomy. There is extensive thermal destruction according to various positions of the adenomyoma or this tissue, and creation of scar tissue which disrupts tissue cohesion and increases the risk of uterine rupture, and that could be unsafe in a possible future pregnancy. In ART IVF part or ICSI part, presence of microfoci and abnormal microenvironment might causes various problems in nidation and its progress. IVF success rates as such are less regardless of good quality of oocyte or embryo quality, and we should think of specific protocols now on or in future for ovarian stimulation, particularly in this type of high pregnancies. So this is the reference and cross references are used to prepare this presentation, and in conclusion, complex are evaluated based on the symptomatic relief and obstetric outcome. A thorough counseling is a must, and this patient should be informed about all the possible adverse outcomes and in the adenocomplex with pregnancy. It should be considered as high-risk pregnancy with high obstetric risk and should be referred to tertiary care hospitals or tertiary care centers for appropriate management by multidisciplinary team, and more multi-center studies are needed to achieve safer results and to reduce the complications which I have just highlighted. Thank you very much for this hearing and giving me the chance to speak in this forum. Thanks a lot.
Mohana,
Thank
you want to give any comments?
It was a elaborate, sir has listed all first obstetric outcomes of endometriosis. Very rare cases like spontaneous pneumothorax, spontaneous hemoperitoneum and uroperitoneum we could see. But most commonly what we encounter in patients with endometriosis undergoing pregnancy is, as sir pointed out, implantation failure and miscarriage. Apart from that, in later half of pregnancy, we see a lot of preeclampsia incidents and PPH. The PPH is due to accreta and the increta complex, and we have to be sure that is when we operate on a patient with adenomyosis, be prepared for a PPH.
Yes.
We have to because we should not end up losing the patient, because it is in many of the cases we have landed in doing an hysterectomy also, because this placenta placenta
Accreta is
previa
also very
incidence is also
common.
incidence also it's very quite common, because lot of surprises may happen, and by the time the patient is loses the blood when going into shock and DIC, and we saving the patient will be very difficult for us. So we have to be much more prepared while operating a case with adenomyosis, and every patient is a potential candidate for PPH. We have to keep in mind and operate. And we have the habit of exteriorizing the uterus while doing cesarean section. So we should be careful and see whether the bowel is adherent to that. In forceful exteriorization, we may have end up in bowel perforation also. So those things we have to be careful.
So apart from this, the fetal problems, or the fetus can have early miscarriage. Ectopic pregnancy is also very high, and then small for gestational age and IUG babies are very common, and preterm labor. So these are all some of the fetal problems what we come across. So the first thing is, when a patient with endo and adenoma becomes pregnant, don't be happy, but be prepared to meet all the complications for both the mother and the baby. See, not only if the patient has got only endometriosis, probably the chance of implantation, miscarriage are all lesser when compared to when they have both a combination of endo and adeno, which are found to be very deadly DO combination. Sir, do you want to add up anything? I think you have covered the entire topic on obstetric management. Thank you, sir. A senior person should do, an incidence of C-section is very high. And as Mohana has said correctly, when you are trying to remove exteriorize the uterus, you may not be able to do it. So in such cases, when there is atonic PPH, there is definitely problem in doing an hysterectomy also.
Next, thank you.
Thank you, sir. So next, I call upon Madam Hepzibah Kripamani. Sir, stop sharing your PPT, sir.
Okay. Yeah. Yeah.
Jignesh, please show Dr. Hepzibah Kripamani's CV, please. Yeah, Professor Hepzibah Kripamani, I should be proud to say that she was my role model. She has got wonderful academic excellence. She is a postgraduate student of Stanley Medical College. She had been conferred with FRCOG and PhD and DSc, where many of the physicians have to think about it in future. And then currently she's a consultant at Kalyani Multispecialty Hospital, and she is the past president of OBGYN Society of Southern India, past president of Chennai Menopausal Society, joint treasurer of IMS, and then treasurer IMS and SAFOM's council member. She has received 2 years consecutive years Best Society Award on behalf of the Menopausal Society, research member, and she has published many papers, and she is a PhD guide for so many of us, and she's trained in robotic surgery, given orations, many orations had been delivered by Dr. Hepzibah. Field of interest is high risk obstetrics and menopause and medical education. Okay, and I'm very proud to say I was mentored by Madam Hepzibah Kripamani. She is my role model. Thank you, madam. Over to you. Today she will be talking about menopause and endometriosis. We always say that at the end of menopause, the endometriosis disappears. It doesn't do so. It starts from womb and ends in tomb. So that is how endometriosis stretches its wing across the entire lifespan of the woman. Madam, over to you. Any problem? Hepzibah, madam, are you having any problem in sharing your screen? Yes. Madam, switch off one unit. I think you have logged in from 2 devices. Switch off your one device. Yeah.
Volume down from one device.
One device, yeah. Put off your mobile, madam. Madam, please put up your mobile. Mobile you can, yeah.
Then please look out from the, then please down, please put down the volume from one device, just only mic. माइक को ऐसे ही बना दीजिए, अपने वॉल्यूम को डाउन कर लीजिए, 2 डिवाइस से सुनिए मत, एक ही डिवाइस से सुनिए. I have joined my laptop and my mobile is switched off. And I switched off the
Yeah.
At your sharing, don't share volume, just on the screen. Click on without volume. Share without volume.
No, when I share, when I talk itself, it is echoing. Hello?
Yes, madam.
I don't think there is problem in my system. I can share.
Madam, you have logged in from 2 units, madam. 2.
My mobile is switched off. My fan is switched off.
Ma'am, I think your phone is not switch off.
You switch off the phone.
Hello?
Try to rejoin again. Leave the meeting and click again join.
Shall I go out and join?
Yes, ma'am. Yes, ma'am.
Okay. Is it okay?
Yes, madam. Now it is okay.
Let's see once I share my.
It's okay, madam. No.
It is seen?
Yes, madam. Now it is clear.
Okay.
Right.
I switched off the fan also.
Okay. Full screen, madam. Now now it is perfect.
Thank you for the opportunity and thank you to see the progress of Dr. Amrit Devi. We are proud of you. Lots of publication in the journal also we saw recently. Thank you so much for the opportunity. When the topic is given to me, a few questions came to my mind. What is its incidence? What is its pathology? What is its clinical presentation? What are the diagnostic modalities available, treatment, and the risk of malignant transformation? So as you all know, the endometriosis, 196 million women suffer from endometriosis globally. And endometriosis is seen in 7.1% of perimenopausal and 2.6% of postmenopausal women. And endometriosis should be viewed as a chronic inflammatory disease that requires lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedure. And the first surgery should be a good surgery. And endometriosis is not a problem of solely reproductive years. And there are also some misunderstanding around endometriosis, including that hysterectomy, pregnancy, and menopause will end the pain. That is not always the case. So endometriosis should regress in parallel with the regression of gonadal steroidogenesis during menopausal transition seems like a perception. The elevation in symptoms during menopausal transition has not been shown in longitudinal studies at the tissue level. So 250 years it took to report that postmenopausal endometriosis. And as we all know, what is perimenopausal period? It is the period 2 to 8 years preceding menopause and last up to 1 year after last menstruation. Actually, perimenopausal endometriosis is a challenge for attending doctor and a patient. And there are a lot of incidents, age group between 40 to 45 years. And it was actually 40.33% admitted to the hospital were treated for endometriosis over the age of 40 years. And another study they found, and 46 patients had postmenopausal endometriosis and 16.7 had perimenopausal endometriosis. So coming to the pathology, it is a complex. We really do not know whether it's a continuation of previous disease or it develops de novo. And other causes they are postulating, it's a probable cause, it's a metaplasia, induction of endometrial implants through continued gonadal steroidogenesis. It can be due to exogenous estrogen administration or peripheral aromatization by adipose tissue and in situ aromatization within cycle of estrogen stimulating cyclooxygen activity. Prostaglandin might stimulate aromatization. So what happens to endometriosis around menopause? The traditional thing, what we think, estrogen decline causes endometric lesion to regress. But in reality, the lesion may remain biologically active, deep infiltrating disease may persist, fibrosis and adhesions can continue to cause pain, ovarian endometriosis may persist, symptoms may become less cyclical, exogenous estrogen exposure may reactivate symptoms in some women. So less estrogen does not necessarily mean no endometriosis. So what happens when the ovarian function decreases, estrogen becomes erratic, anovulatory cycles become common, and menstrual irregularity and along with vasomotor symptoms can develop. So the phenotype may change. So it's a challenge for the challenge to diagnose. The patient may have both endometriosis related symptoms and menopausal symptoms simultaneously. So we all know the endometriosis symptoms of pelvic pain, dysmenorrhea, deep dyspareunia, irregular periods, bladder symptoms, chronic pelvic pain. And along with that, they can have hot flushes, sleep disturbance, mood changes, vaginal symptoms, and cognitive complaints. So it can overlap the pelvic pain, irregular bleeding, sleep disturbance, mood symptoms, and bowel symptoms. So there are different changing clinical phenotype. So here in reproductive age group, it is pelvic cyclical pain. It can be persistent or atypical pain. Dysmenorrhea, apart from dysmenorrhea, there may be a new pelvic pain in perimenopause. Dyspareunia, here also deep pelvic rectal symptoms will be there. Bowel and bladder symptoms is cyclical. Here it's a non-cyclical symptoms. Infertility, of course, they can come to you as infertility patient. Here, mostly the pain and menopausal symptom. And endometrioma can persist, the persistent ovarian lesion in perimenopause and menopause. So when there is a change in pattern of pain, they need reassessment. It is a red flag for us. You have to think in terms of endometriosis. So the new pelvic pain in perimenopausal women considered. Along with that, it can be due to adenomyosis, fibroid, and ovarian cyst and endometrioma. So the clinical presentation may be a pelvic pain or a mass symptom may be related to the location of the endometriotic lesion. Many different locations of postmenopausal endometriosis have been described. Even a cutaneous endometriosis has been reported in postmenopausal women. Intestinal and urethral obstruction and a case of hepatic endometriosis have also been reported in literature. So, diagnosis of endometriosis purely based on history, symptoms, sign, corroborative physical examination, imaging test, but finally it should be proven by histological examination. So, the combination of the gold standard for diagnosis can be a combination of laparoscope and a histological confirmation of the disease. So, as we all know, the diagnosis can be, imaging modality is very useful. It can be a TAS or TBS or MRI. TAS, you can see a ground glass echogenicity, 1 to 4 compartment, no papillary structures with a detectable blood flow. In TBS, the rectal endometriosis is easily picked up and it is an operator dependent, and usually we don't recommend to diagnose rectal endometriosis. MRI can be used to assess ureter, bladder, bowel involvement. You should be aware that usefulness of MRI to diagnose is established. So coming to the biomarker, there is no need to use biomarker in endometrial tissue, menstrual or urine fluid or immunological biomarkers. And CA125 in plasma, urine or serum to diagnose endometriosis, but raised serum CA125 may be consistent with having endometriosis. Endometriosis may be present despite normal serum CA125. CDG recommends that clinicians should not assess ureter, bladder, and bowel involvement, should assess ureter, bladder, and bowel involvement by additional imaging if there is a suspicion based on history or physical examination of deep endometriosis when we want to do further management. So the associated conditions are ovarian paravorensis, fibroid, adenomyosis, carcinoma, bowel cancer, and uterine cancer. So the treatment goal will be, we have to alleviate pain, reduce recurrence, and improve quality of life. The challenge, we need both endometriosis in perimenopausal age group, endometriosis treatment, and menopausal management. So coming to management, surgical, medical, and combined. So the important consideration in this age group include diminished fertility and impending menopause. So the diagnosis and treatment of endometriosis associated infertility must be undertaken in an expected and faster manner. So all the societies, ICOG recommends hysterectomy with BSO is a definitive treatment for adnexal mass or multiple previous conservative surgical procedures in women in whom conservative medical and surgical management failed, and the ESHRE guidance recommend a definitive surgery, hysterectomy with BSO, together with all removal of all visible lesions for a woman who has completed the reproductive arc and have persistent symptoms despite medical therapy. And NICE guidance also indicate the visible lesion to be excised, but FOXI doesn't have a definitive guidelines. And the first choice of treatment mainly is to reduce the risk of malignancy, but before carrying out, it also has a risk. Such cases are older when compared to the cases at reproductive age group, thus they have comorbid condition. These patients may have previous surgeries, according to may have higher operative risk. Nevertheless, surgery should be considered, explained, and offered to these patients to prevent recurrence and malignancy. So before embarking the surgery, we have to rule out irritable bowel syndrome. They also mimic cyclical pain and interstitial cystitis and vertebral pathologies we have to rule out. So the surgical technique should be individualized and it should take into account factors such as women's age, pregnancy intention, because these people, many of the younger generation get married late and they want to become pregnant around 40 years. And ovarian reserve, fallopian tube patency, and recurrent status. So this is again an ovarian endometrioma. It's really a challenging to make a decision. And there is a little difference to handle these ovarian endometrioma when they have a chance of natural conception. It's different when they have they are for IVF, because they can have a hydrosulfings and require concomitantly the management of other severe local lesion also. So the choice is to remove excision or cystectomy, destroy it in situ by vaporization using laser or plasma energy, coagulate the inner layer using bipolar current, destroy it using sclerotherapy. Ovarian endometrioma, clinicians should perform cystectomy instead of drainage and coagulation, as cystectomy reduces endometriosis-associated pain. And again, the secondary prevention of endometriosis associated with dysmenorrhea and dyspareunia for endometrioma more than 3 centimeters and the clinician should perform ovarian cystectomy instead of drainage and electrocoagulation. After cystectomy for ovarian endometrioma, in women not immediately seeking conception, the clinicians are recommended to prescribe combined oral contraception for secondary prevention. In women operated for endometriosis, clinicians are recommended to prescribe post-operative use of LNG, combined hormonal contraceptive, or at least 18 to 24 months as one of the options for secondary prevention of endometriosis associated dysmenorrhea, but not for non-menstrual pelvic pain or dyspareunia. Performing oophorectomy rather than cystectomy in women with no further pregnancy intention may be advocated in case of high risk recurrence risk. The CDG recommends that clinicians counsel women, the endometriotic, regarding the risk of reduced ovarian function after surgery and the possible loss of ovary. The decision to proceed with surgery should be considered carefully if the woman has had previous ovarian surgery. There's a lot of counseling is required before we do surgery. So surgery and long-term suppression is based on patient requirement. If there is a unilateral endometrioma, surgery followed by LNG gives excellent relief. Hysterectomy with or without PSO is family completed or persistence of severe. Other LUNA and PSN is not effective. And post-operative follow, we have to give GnRH analog, COX, and Dynagest and LNG IUS. So recurrence after hysterectomy are seen. Recurrent symptom after TAH occur in 10%, and reoperation rate after TAH without BSO is 85% within 5 years. But there is no sufficient data of recurrence after tubal ligation. So the persistent endometriosis following surgery and medical treatment might be preferred, but endometriosis should be confirmed before embarking on a medical treatment. For recurrent endometriosis, conservative surgical approach is not shown to be effective. However, the postmenopausal woman, there are no data on the benefit or otherwise a conservative approach in this low estrogen environment. In one of the reports, 75 cases of recurrent endometriosis, bowel involvement was reported in 33%, and they have to undergo reoperation. So, coming to the medical management, it can be a combined oral contraceptive, norethistrodon, Dynagest, GnRH agonist, and aromatase inhibitors. And CDG recommends aromatase inhibitor in women with pain from rectovaginal endometriosis refractory to the other medical or surgical treatment. Clinicians can consider prescribing aromatase inhibitors in combination with oral contraceptive pill or progestogens or GnRH analog as they reduce endometriosis associated pain. So treatment, the first reported regarding use of aromatase inhibitors, the success of therapy in 57-year-old women had presented with recurrent endometriosis, painful vaginal polypid mass, and had been decreased by 50%. And pain disappeared within 2 months. The size of the mass strikingly reduced and at the end of 6 months of therapy. So there is a place for aromatase inhibitors. In deep endometriosis, CDG recommends that clinicians refer women with a suspected or diagnosed deep endometriosis to a center of expertise that offers all available treatment in multidisciplinary context, because there may be a bowel and urethral environment, better to have a multidisciplinary approach. The surgical removal of deep endometriosis, but it reduces associated pain, so and improves the quality of life. And CDG again recommends that clinicians consider hysterectomy with the removal of the ovaries and all visible endometriosis lesion in women who have completed their family and failed to respond to more conservative treatment. And it should be informed that hysterectomy will not necessarily cure the symptoms or the disease. Sometimes that can be recurrence. Coming to the tamoxifen has got an effect on the endometrium. So the effect of the tamoxifen endometrial tissue, as well as a lot of cases, they up to date, it concluded that tamoxifen used in postmenopausal women with breast cancer might increase the risk of endometriosis. And coming to HRT and endometriosis, there is a risk versus benefit when we consider the existing guidelines emphasize lack of evidence, but suggest that women should not be denied of HRT treatment simply because of history of endometriosis. That women with a history of endometriosis should be carefully counseled about the possibility of the recurrence after menopause, but the potential risk of HRT, it is very substantial and benefit should not be overlooked. We have to counsel and highly individualized treatment we should offer them. And the benefit can not be overlooked. Benefit may outweigh the cost of HRT or a woman with an early or surgical menopause. HRT has been shown to enhance cortical volumetric bone mineral density and a compressed strength, and a lot of other benefit also, and dementia and cognitive improvement associated with unilateral bilateral hysterectomy prior to the onset of natural menopause will be reduced if HRT is administered until the average age of natural menopause. So the benefit also is more. So again, the CDG recommends that clinicians continue to treat women with history of endometriosis after surgical menopause with combined estrogen and progesterone, or a tibulan with a better option, at least at the age of natural menopause. So we have to give estrogen and progesterone combination after surgical hysterectomy, surgery when they go for surgical menopause, or we can use the tibulan till the age of natural menopause. So there is another study says there is no malignant transformation because of HRT, and they concluded HRT is safe. The risk of endometriosis malignant transformation is 22.5%. The prevalence of endometriosis varies with different types of ovarian cancer. So for serous, it is less. For clear cell and endometrioid type, it is more, somewhere around 35.9. It depends upon the type. Ovarian endometriosis is especially associated with clear cell or endometrioid and a low-grade serous tumors. It is usually not associated with high-grade serous tumors or mucinous tumors. So, what is the relationship between endometriosis and malignancy? Because all or a certain proportion of cases of endometriosis may be pre-malignant lesion, and in addition, environmental, endocrinology, epigenetic, and genetic factors may be the etiological for both endometriosis and for malignancy type. There may be a metaplastic component of the malignant transformation also plays a role. So endometrioid carcinoma of the ovary and endometriosis, there is an association in the postmenopausal. Some studies they have told. They have reviewed 42 patients with endometrioid ovarian carcinoma and found that ovarian endometriosis was present in 11 cases, that is 26%. In 4 patients, the carcinoma and endometriosis transition was observed. They thus suggested that ovarian endometriosis has a potential of malignant transformation in postmenopausal women, and if found, should be surgically removed. So again, the CDT recommends that the clinicians inform women with endometriosis requesting information on the risk of developing cancer, that some cases, ovarian cancer and non-Hodgkin lymphoma, are slightly more common in women with endometriosis. Perimenopause endometriosis and early menopause. Women with endometriosis appear to be more likely to experience early menopause, and psychological impact of endometriosis may be there in perimenopause endometriosis. So the management of endometriosis women approaching the end of reproductive life requires special attention due to the potential for recurrence and transformation into various malignancies. So it's not only the disease of reproductive age that can happen perimenopause also. Suspect post-perimenopausal endometriosis when symptoms appear in already known cases or a new symptoms appear in perimenopause women. Surgery is indicated when medical management fails, but discuss about the outcome because comorbid conditions may be associated with. Conservative surgery is possible in early perimenopause in this era when women need conception through ART. Risk of malignancy is slightly higher in perimenopause. So, the endometriosis life is like this. Starts at 20, progress at 30, problematic at 40, supposed to end at 50, and malignant risk increases at 60. Hence, they need follow-up forever. So, we have to keep an eye on perimenopausal and postmenopausal women when there is a new symptoms, when there is a history of fibroid, adenomyosis, endometrioma, can pick up peri and postmenopausal endometriosis earlier. So we have to have a vigilant watch on these people. So challenges are what make life interesting, and overcome them is what makes life meaningful. So perimenopause endometriosis presents a challenges in diagnosis. So we have to determine the objective of therapy, not only and not to delay the recurrence, and appropriate treatment can give them meaningful life. And thank you for patient listening.
Thank you, ma'am. It was an elaborate presentation, and you have taken us through the menopausal changes happening the adenomyosis, and we had a very good clinical approach on that. But after ruling out the malignancy, the patients they respond very well to medical therapy because already the estrogen is declining. So now a lot of newer drugs have also come in. What is your experience with the oral antagonist, elagolix?
So,
For
in peri and post, it's better we do a surgery, first line of therapy. All the recommendation says surgery because the risk of potential malignancy is there. So maybe post-operative, you can try all those things. A medical management post-op. So first surgery, medical and combination.
I agree with you, madam, because by there is definite increase in the incidence of ovarian malignancy and adenomyosis, you have endometrial malignancy. So by doing hysterectomy with bilateral salpingo-oophorectomy, you are reducing the risk of ovarian, tubal, uterine, cervical malignancy plus the breast malignancy incidence also reduced. So it's my general advice to any patient with endo and adeno, once when they cross 45 years, if they are symptomatic, I think it is better to go ahead with the hysterectomy with bilateral salpingo-oophorectomy. And
additional lesion, if there is present, that also it's better to remove.
Yeah. Then post-operatively, these patients, they need to be suppressed minimum for a period of 2 years.
18 to 24
And minimum 2 years or 18 to 24 months, as you have said. And the drug of choice, as you have now any sort of progestin. And among the progestin, the least it cost is DMPA, but it is excellent. So we can always go in for a simple, low-cost DMPA post-operatively for at least for a period of 1.5 years to 2 years. So postmenopausal endometriosis has to be viewed with caution.
Thank you, ma'am.
Mm.
Let's go.
So the third and the final topic is mine.
Yes,
I will share my screen.
It's a great privilege and pleasure to introduce my teacher, ma'am. Ma'am doesn't need any introduction, but I want to say a few words about her. She's an eminent academician and an inspiring clinician who has been guiding force for many of us in our professional journey. She's going to speak on the exciting evolving topic, the biomarkers of endometriosis. We all know endometriosis is a challenging condition. So a search for a reliable non-invasive biomarker could potentially transform the way we diagnose and manage endometriosis early. So madam is an apt person with immense experience and knowledge and passion for endometriosis. Over to you, madam.
Thank you, Mohana, for your kind words of introduction. See, as you have rightly pointed out, all the guidelines, they say that biomarkers in endometriosis are not to be taken into clinical practice. But I am sure ESHRE specifically says, the recent ESHRE guideline says that biomarkers role is only under clinical research setting. But I am sure the subsequent ESHRE revisions will definitely have a role for biomarker. Similar to this PLGF and SFLGT on in cases of hypertensive disorders, this will also gain popularity one too. I bring you greetings from Tiruchirappalli, my hometown, where you can see the beautiful river Kaveri and the rock fort, as well as the 1,000-pillar temple, that courtyard at Srirangam. So the newer methods of diagnosis of endometriosis is very important. Why? We need to pick the lesion at an earlier stage. If we start the treatment at a much earlier stage, probably the disease may not progress, probably. And then the patient will have relief of pain and the fertility can be preserved. So now the focus on non-invasive biomarkers are using markers from the blood, urine, menstrual blood, which is a direct reflection of the endometrial cavity, microRNAs, microarrays, serum, other biomarkers, And there is definitely a role for artificial intelligence in these non-invasive biomarkers, which can help us to pick it up very early. And there has been recent idea suggestion given by the role of salivary mRNA, which has been brought into practical application by using a salivary kit test that has been developed by Dr. Philips Deschamps, who was the past president of European Board of OBGYN. So the objective of my talk is to review the limitation of current diagnosis, because by the time we diagnose endometriosis, it is quite a lot of diagnostic delay and the symptoms are variable. So the same symptoms may not be present for each disease, and each phenotype has got a different symptom. Then to summarize non-invasive biomarkers that are available on research basis and highlight that blood, urine, menstrual fluid, saliva, and serum biomarkers. And we need to discuss about the microRNA, microarray, and AI-based diagnosis. Why this topic matters? Because more often endometriosis is a very common disorder. I would say it is much more than the PMOS, and it is often underdiagnosed. And the symptoms, as I said earlier, they are not specific, and the diagnostic delay remains a major issue. Earlier diagnosis can improve care and counseling. So these are all the endometriosis. Once we thought it was a chronic inflammatory disorder that is characterized by the presence of tissue, endometrial-like tissue outside the uterus. But we have an added thing, that is, it is a neuroangiogenic inflammatory disorder. So the symptoms are, most important is the endometriosis associated pelvic pain, which I am very fond of calling it as 7Ds, that is dysmenorrhea, dyspareunia, dysuria, dystasia, difficulty in conception, diffuse abdominal pain, and depression, which will ultimately lead to fatigability of the patient. Again, there is a constant association between autoimmune disorder and endometriosis, and the patient can have irritable bowel syndrome, ulcerative colitis, etc., and headache because of chronic fatigability and depression. So it is generally managed by surgical or medical management, dietary modification, and we have digital apps which can pick up and which can connect with the consultants. And then, of course, physiotherapy, mindfulness, and cognitive behavioral therapy. So the diagnostic delay is huge. From the onset of symptoms to the patient to get the proper treatment or confirmation of the disease, it takes a long way. It may vary from 2 years to 9 years. And the patient would have visited so many consultants, starting from pediatrician, general practitioner, surgeon, physician, and then even including psychiatrist. So then the diagnostic delay again depends upon the phenotype as well as the symptoms of the patient. So repeated symptomatic treatment is common before confirmation. That is, before we know that the patient has got definite evidence of endometriosis, we treat them symptomatically with NSAIDs. So that we need to have a reliable, non-invasive triage test, which is still lacking. So this is a picture to show how much of diagnostic delay is there based upon the pain. If the patient has got a chronic pelvic pain, maybe the patient may take 5 years, dyspareunia again 5 years, and then micturition problem 4 to 5 years, dysmenorrhea 12 years, because most commonly the women who develop progressive dysmenorrhea at a younger age, they are said that dysmenorrhea is likely to regress once when they get married. And then bleeding problems and infertility and atypical pain and abdominal mass, wall mass, that is invariably the scar endometriosis, usually the diagnosis is picked up very early. And when it is going to be an ovarian endometrioma, it may take 4 years. Deep infiltrative endometriosis can take 7 years or to 10 years. And adenomyosis, now it is uncommon to see adenomyosis even in a young girl. And as I said earlier, abdominal or endometriosis, you can pick it up very easily. Diagnosis is often delayed. Pain can become long-standing if gets untreated, and it can cause a lot of disabilities. Patients often need long-term care rather than one-time management. So then the current diagnostic pathway is the patient gives the clinical history, we do a clinical examination, and then we depend upon the ultrasound and MRI for mapping and triaging. Then we always go in for a laparoscopy and histology when needed. And laparoscopy was considered to be the gold standard in diagnosis of endometriosis. Biomarkers definitely can support earlier suspicion. So this is the stepwise approach: clinical assessment following imaging, surgical evaluation, and biomarkers. So here in imaging, in patients with early lesions, the imaging is totally negative. But now with the advent of high frequency emissions and people who are involved in imaging in endometriosis with excellence, they can pick up even a stage 1 and stage 2 endometriosis. So early and accurate diagnosis is the key to the better management. So what are the biomarkers? Why we are depending on the biomarker? Biomarkers has got clear impact in reducing the diagnostic time and then monitoring the progress of the disease, follow-up of the treatment. To replace invasive diagnostic methods, and biomarkers could be considered clinically useful. And to say that it is a valuable biomarker, the criteria should be, it should have a sensitivity of 94% and specificity of beyond 79%. So that definitely reduces the diagnostic delay, and it will increase the patient, improves the patient's acceptability, allow repeated testing over a time, support outpatient triaging. The thing, mainly the thing is, if you tell from based on the symptoms that the patients are having endometriosis, initially they may not accept because they everybody thinks that dysmenorrhea is very common in that age. So by at least supporting with some form of triaging test or the biomarker, it can help them to like start the treatment earlier with a better patient care, and it can also be continuously monitored. So these are all the very many biomarkers that are available. They can be either the growth factors, EGF, EGFR, IGF, and so many other things. Then you can have the glycoprotein. The common glycoprotein, what we do is the CA125, CA199, and CA72, and so many other things are there. And angiogenic factors, that is SFLT1, and then VEGF and VEGF, as well as neural growth factor. Then apoptosis. Apoptosis, we have a fast 3 gone. That is, in what happens in endometriosis is there is promotion of apoptosis because of the anti-apoptotic factor that is depressed here. Then we have the hormones: prolactin, leptin, TSH, LH, FSH, E2, progesterone, and testosterone. And we find progesterone resistant, which is the hallmark for endometriosis. Again, other biomarkers are vitamin D binding protein, amyloid A, TM, that is a tissue inhibitor of metalloproteinases, matrix metalloproteinases 2. Urocortin is found to be an important biomarker in the urine, and cell-free DNA, CRP, ICOG, and ICOG. And apart from this, we have the proteomics and metabolomics, which can also be used. And being an immunological disorder where the immunology is brief, the antibodies like autoantibodies, anti-DNA, anti-RNA, anti-cardiolipin, these are all some of the antibodies that can be used as a marker, and complements like C3, C3A, C3C, etc. Then if cellular immune alteration is because of the presence of this alteration of the T cells, B cells, and NK cells, and leukocyte protease inhibitors, then they have cytokines. This being an immunomodulatory immune complex disorder, the cytokines are all abnormal, and the cytokine starts producing pro-inflammatory substance, and the tumor necrosis alpha and TGF beta, all those things are elevated. So the potential thing is inflammation, interleukins, HMG beta 1, and tumor necrosis alpha, immunological NK cells, integrins, T cells, and B cells. Bioimaging, we have the transvaginal ultrasonogram and MRI, and then metabolic and mitochondrial abnormalities can present in the way of amino acid, lipid, abnormal amino acids, lipids, purine metabolites, and energy metabolism markers. And hormonal, we have already discussed. And we know now that it is a disease that is genetically or epigenetic changes are there, leading to dysregulation of non-coding RNA, cell-free DNA, and DNA methylation patterns, which are a hallmark of epigenetic. Here, this is an anthropometric technique. This is nothing but a simple calculation of the anogenital distance. That is from the posterior fracture to that of the anterior anal verge. If you can measure, this is less than 20 millimeters or 2 centimeters, it is diagnostic of endometriosis, which we can pick it up by MRI. So this is a simple, non-invasive, repetitive testing for which can be used as in diagnosis. Then comes the other biomarker sources that are under study: blood, serum, urine, saliva, menstrual blood, and again the exosomes and the circulating nucleic acids. See, I'll tell you what is that exosome and what is that microRNA. Multi-omic signature. So each disease has got its own signature in the multi-omic study, and there are here these are all found in so many other things. And microRNAs are nothing but we have more than 2,500 microRNAs that are circulating in the body, and each microRNA, a group of microRNAs are specific for particular disease. They are usually present inside the exosomes, and they are very stable. They are not usually degraded easily, and hence it can serve as a potent biomarker. So the blood-based biomarkers are very practical, promising, scalable approach for early detection. It is easy to collect the blood, more practical for screening purpose, and it includes the study from the blood can include proteins, cytokines, and nucleic acid, and the results vary between the studies. So what we are measuring is, we can measure the protein, the CA125, HE4, interleukin, T necrosis alpha, and MMP, cytokines, interleukins, and then nucleic acid, that is the cell-free DNA, then the mitochondrial DNA, and microRNA. So the takeaway is blood-based markers are most advanced and feasible for translation into clinical practice. When to collect the sample? So we will have a doubt because the basic changes of the menstrual period, whether you have more sensitivity and specificity and a good AAC curve during proliferative phase or during secretory phase. There is not much of difference between whether you collect the sample at proliferative or secretory phase, but we see that there is a subtle increase in the performance when we collect the samples in the secretory phase. Then there are still, these biomarkers are not without limitation, because many biomarkers lack disease specificity and you can overlap. For example, a patient with endometriosis, if they are having a PCOS or PMOS, it can overlap, and then these common microRNAs are shared between the two diseases. Then the second point is it is affected by cyclic phase and disease phenotype, and hormonal fluctuations and varying disease stages lead to inconsistent results. The third one is we don't have larger studies. We have only small cohorts that with reduced reliability. More studies we need, and we need to have a larger samples from and invariably the studies that are available currently are from a single center, that is limiting the generalized use of this particular biomarker. No single biomarker is inadequate alone. Endometriosis is a complex multifactorial disease. No standalone blood marker can have sufficient accuracy. So the takeaway is blood biomarkers are helpful in pieces like small pieces of puzzle, but not the whole picture. So then there are newer candidates, serum candidates. The proteomic study has been identified several promising serum biomarkers beyond CA125. One is that alpha-1 antitrypsin, which is elevated in endometriosis. Basically, it is a result of inflammation, protease inhibition, and tissue remodeling. Vitamin D binding protein, altered levels linked to immune modulation and inflammation and pain. Complement related, being a immunological disorder, it has got components such as C3, C4, and factor B are consistently dysregulated in endometriosis. And inflammatory and immune mediators like cytokines, chemokines like interleukin 6, tumor necrosis alpha, and MCP1, which will reflect the chronic inflammatory milieu. So there are multiple pathways which are involved, and either instead of taking a single agent as a biomarker, a panel of biomarkers will be more useful. Then urine markers. The urine offers it is a very comfortable, convenient, patient-friendly alternative. You don't even need to have a break. It is completely non-invasive sample, suitable for repeated testing, easy OPD collection, and attractive point-of-care testing development. So it is safe, non-invasive, repeatable, outpatient-friendly point-of-care testing. Why it matters? Urine reflects systemic and local biological changes that can capture dynamic disease process. So the takeaway is urine as a urinary marker is a practical, reproducible, scalable source for non-invasive diagnosis of endometriosis as a biomarker. Then comes the menstrual blood markers. Biologically, it is a very, very reliable sample because it originates directly from the site of the disease and reflects the local pathology. It reflects the endometrial and inflammatory activity. It contains cells, proteins, cytokines, and nucleic acid. Non-invasive and patient-friendly. It can be collected very easily with a minimal discomfort and safe for repeated sampling similar to urine. Collection and processing needs standardization. We need to collect it in menstrual cups, and then the menstrual fluid contains cells, that is the endometrial and immune cells, peptides and polypeptides, extracellular vesicle, that is the exosomes and the microvesicles, proteins like cytokines, chemokines, and growth factors, nucleic acids like DNA, RNA, and microRNA, and metabolites like lipid mediators that reflects the oxidative stress. Emerging studies have identified protein, cytokine, and microRNA signatures are associated with endometriosis severity and phenotype. And the takeaway is now menstrual fluid can be used as a promising source for as a biomarker, but methodological standardization and large-scale validation are essential. Then comes the menstrual fluid proteomics. I've said already that proteomics and genomics, they have a proteomic profiling is specific for similar diseases, and they have a shared candidate protein that has been reported across multiple studies. They are inflammatory proteins, may complement each other, blood and urine testing for better diagnostic accuracy, and still early for clinical application and robust validation is needed. So what they do is they collect the menstrual blood through menstrual curve, sample is prepared, and it is subjected to analysis, data processing, and there is protein identification through the pathway, and they also use AI for this. So then other protein categories frequently identify are inflammatory proteins, immune response complements, extracellular matrix addition protein, apoptosis survival, annexins, BCL2 gene, etc., oxidative stress, and metabolic protein. So the menstrual fluid proteomics show promise for endometriosis biomarker discovery, but requires larger and again standardized studies. So then comes the epigenetic. All of us know that there is dysregulation in the genetic and the epigenetic changes that will lead to histone modification. MicroRNAs and the ribosomal RNA and long non-coding RNA are altered, and in the presence of estrogen dominance, they can promote inflammation, proliferation, angiogenesis, and impaired deserialization. And there is again a progesterone resistance that is obvious in any endometriosis patient. So you can make use of salivary microRNA, as I have said. Dr. Philip Stamps has come out with the salivary microRNA testing. Peripheral blood can be used for cell-free DNA, and they have found out that endometrial cells, circulating endometrial cells in the patients with endometriosis in the peripheral blood. Then again, cervical and uterine ribosomal RNA. And the clinical outcome is in patients with pain, AUB, and infertility, if their symptoms are suggestive of endometriosis without any evidence in imaging, then it can be tried. Then microRNA. This is microRNA is my field of interest, where they are nothing but short non-coding RNAs, lesser than plus or minus 22 nucleotides, that fine-tune the gene expression. This gene expression, it is altered according to the disease, and they are dysregulated. So from the DNA, mRNA, that is transcription pathway, and then it gets into the microRNA, binding is there. Inhibition of this translation of microRNA, mRNA degradation is there. And finally, the decreased protein production is there. So the post-transcriptional regulation of gene expression is controlled by this. So this is being controlled. So this regulates the post-transcriptional gene expression. MicroRNAs, they bind to the target mRNAs and inhibit the translation or promote degradation, controlling the key biological pathways. So that means if the mRNAs are dysregulated, it affects biologically the transcriptional gene expression at the level of mRNA. And they are stable in multiple body fluids, as I said, that they are preserved within the exosomes, and it is very difficult to degrade it. Then comes hence they can be used as strong candidates for non-invasive diagnosis, suitable for screening, early detection, monitoring, and prognostication. They reflect the disease biology more directly. MicroRNA expression changes the mirror molecular alterations in endometriosis, including inflammation, fibrosis, angiogenesis, and pain pathways. So these main pathways, inflammation, they have a certain group of miRNAs, fibrosis, they have certain groups. So finally, each abnormality is being dysregulated. miRNAs are responsible for that. They are stable, accessible, and biologically relevant biomarkers with great potential to improve non-invasive diagnosis. And not a single one, but it should be a panel of microRNAs that should be used. And the most common is in MIR 21, 200, 231, 125, 199, and beyond this 150 can also be used. So initially the sample is collected, that should be profiling by doing an RT-PCR, and then it is subjected to machine learning or AI models, and you have the AUC curve generated as well as the sensitivity and the specificity. So that can be applied clinically. These panel of endometrial microRNAs are very, very promising, and machine learning, as I said, it can have a strong performance and validity can be made. The clinical translation is still incomplete because of limited external validation. There are multiple reports with improved AUC curve for serum microRNA panels, and anything beyond 0.85, it is found to have a good AUC curve. And as I have mentioned earlier, the sensitivity and the specificity should be beyond 90 sensitivity, and specificity should be beyond 80 at least. So this validation, this RT-PCR validation showed reduced performance in many studies, and hence there are different platforms and cohorts and normalization. So there is slight variation from one study to other. So the takeaway is serum microRNA panels combined with machine learning models show high potential for endometriosis diagnosis, but robust validation and standardization are essential before it can be used for clinical implementation. So this is the method where the lot of authors have done a lot of work, and they found to have a higher sensitivity and pooled specificity, pooled AUC curve, and the diagnostic accuracy, and it is found to have an overall promising role as a biomarker. So the key takeaway is current meta-analytic evidence supports that potential miRNA are diagnostic biomarkers for endometriosis, but the heterogeneity and lack of standardization limits the clinical implementation. So this is the salivary test, what I was telling. So they have brought out to the commercial kit called as Zivic Endosis kit that is available. So you have just need to, the patient with suspicion of endometriosis can just take a saliva by means of some patch of spatulas, and then they can put it. It can be stored and it can be transported where in the main lab they can process it. So this test is available in European countries, and this is costing somewhere about high levels. There is some thousands of euros it is costing. So then comes the exosomal microRNA. I said these exosomes are nano-sized vesicles which are released by the cells into the body fluids, and then they contain miRNA, protein, lipids, mRNAs, and other bioactive modules. So exosomes, they prevent this from degradation, and hence it can be stored as a stable biomarker, and it reflects better reflection of the lesion biology. The emerging area with translational potential, it is a novel source for biomarker diagnosis, prognosis, and monitoring, and it could be used as a point of care testing. So the sample it is collected, exosome is isolated, miRNA is extracted, and it is quantified, and data analysis is done. So the advantages, it has got a high stability, disease specificity, non-invasive, compatible with multi-omic study also. Then comes the higher version, that is the microarray testing, where this miRNA can be RNA can be extracted, labeling and hybridization can be done, fluorescence scan with a single capture, and data can be analyzed. So this is useful for discovery of differential expression of the signature, identifies multiple candidate pathways in a single at once, and helpful for diagnosis of inflammation, angiogenesis, and invasion research, and requires downstream confirmation. So finally, this takeaway is microarray studies are invaluable discovery platform that can provide broad insights into gene expression and pathways in endometriosis, but results must be validated and integrated with functional data. Then transcriptomic signatures, same way sample collected, RNA extracted, sequencing, gene sequencing done, data analyzed, and the pathway instruction. So there is differential expression of common pathways like immune response, extracellular matrix remodeling, angiogenesis, cell additions, and invasion. So this can be used in future but we need to have a lot of trials and studies before it gets validated. So then multiomics, I have already mentioned, this either proteomics or transcriptomics or mRNA post-transcriptional regulators can also be used, and it should be complementary to each other. And instead of a single one, panel can help. And in future, multiomic integration is a likely pathway towards the reliable non-invasive testing. And AI has got a lot of role in diagnosis by using machine learning. It can identify the useful complex heterogeneous disease, improves the prediction and risk stratification. External validation remains critical. And then this once when it is being applied to machine learning, it gives the output, and this can also be combined with the clinical use. Suppose if you have multiple patients with the certain symptoms and imaging evidence and positivity on how they get treated either medically or surgically. So by application of AI, if you put in the history of your patient, AI can give you what the patient should be, how the patient should be handled. So the traditional models can have AUC evaluation of only up to 0.78 and sensitivity around 75%. But machine learning models, if you are going to apply AI, the sensitivity, specificity, and AUC curves are all very high. So AI has got strong potential to enhance the diagnosis of endometriosis. Then this is again using AI in imaging. You can, the transvaginal imaging, AI can analyze, lesion can be detected, and clinical research and support. So you need to pump the AI with a lot of multiple images, which can, when your patient comes, you can feed into this AI model, and then you can come to a diagnosis, what is the exact phenotype and what are the sites where it is being involved, and it can improve the diagnostic accuracy with confidence. So, but there are challenges. One is only you have a small heterogeneous cohorts, assay and handling variability, and menstrual cycle timing need for large multicentric trials, standardized protocols for collecting the sample, harmonized assays, larger diverse cohorts, and multi-center collaboration and robust validation are all needed. So the focus of future research is biomarker can be a good non-invasive diagnosis, medical management can be focused based upon this, surgical or conservative patient-centered can be applied, AI in diagnosis management as well as an ART can help for infertile patients, and plus preventive management can also be there. So to conclude, towards accurate non-invasive diagnosis that becomes an unmet need, the markers are what I have mentioned earlier. MicroRNAs are more promising. Microarray and AL will likely to support future diagnostic pathway. Integrated multimodal testing is the most reliable one. A future where endometriosis can be detected earlier, managed better, and lives improved. So this is what I always say, roots in utero starts at 20, progresses at 30, problematic at 40 because there is increased cardiovascular risk, supposed to end at 50, malignant risk at 60, and needs follow forever. So now I would like to share some of my experience with the microRNA as a potential biomarker. So this study, we initially took 86 patients with endo and control group of 83. We had a pooled microarray, and the microRNAs taken were 125, 150, 342, and microRNA 3613 and lead-7B. So this was the AUC curve we got. With 125, the AUC curve was very good. With 150 and 342, not that much. But whereas when it comes to the question of lead-7B, the AUC curve was very, very high. And probably we took this microRNA 125, D42, and lead-7B as a marker for diagnosis. So when we did the stat analysis, we found out, we compared the control group and the endo group. See, this is the control group and endo group. Here there was upregulation of 125B, MIR 150 and 342, and downregulation of 3613 and lead-7B. So here, this shows that 125 and 342 are highly upregulated and lead-7B is downregulated. And when you compare the stages of endometriosis with the dysregulation of microRNA, irrespective of the stage of endometriosis, the dysregulation was uniform. So the results of our study are when microRNA 125, 150, 342, 3613 and lead-7B are studied in both control and study group, there was upregulation of these 3 microRNAs and downregulation of 3613 and 7B. The conclusion, this study shows that panel of microRNAs in serum can be used as a non-invasive biomarker. So we are probably trying to come out with a kit test which can pick up, can be used as a non-invasive biomarker. So then this is the team with which I work, that is the team from Satyabama University. I think in future, biomarkers are going to help the clinicians in a much way. So thank you for the opportunity, I think.
Thank you, ma'am. You made me speechless. Your talk clearly reflected how much passion you have for endometriosis. This endometriosis itself is a complex topic and the biomarkers are dry for us. But you have clearly explained and made us understand the importance of biomarkers and we have to diagnose early and manage early. And you have given a good update on microRNA panels and also the application of AI in endometriosis. These are all very useful for us. And thank you, ma'am. Thank you for that wonderful, enlightening speech on endometriosis.
Thank you, Mohana. Jignesh, can we move on to the MCQs?
Okay, ma'am.
Yes. How many questions are there today?
15, ma'am.
Okay, okay. So the first question is, serum biomarker is most commonly studied as used as an adjunct in the evaluation of endometriosis, CA 1919, CA 125, CEA and alpha fetoprotein. What is the answer? Correct answer.
CA 120.
Hey, don't tell, because people will be making it, doing it separately. Those people who are watching this. So go to the next one. So the correct answer is CA 125. Okay, next question is regarding CA 125 in endometriosis, which statement is most accurate? It has an excellent sensitivity for early stage disease. Normal CA 125 excludes endometriosis. It may be elevated particularly in more extensive disease but lacks adequate sensitivity and specificity. It is specific for ovarian endometrioma. So tell me, what is the most accurate? Yes, C is the correct answer. It may be elevated particularly in extensive disease, but it lacks adequate sensitivity and specificity because in so many conditions we find elevation of CA125. Next answer. Which of the following is an emerging non-invasive approach for investigating and diagnosis of endometriosis? Circulating microRNA profile, serum troponin, plasma renin activity, serum calcitonin. I think everybody will pick it immediately. So the correct answer is yes.
Circulating microRNA.
Yes. Don't tell. So the Jignesh, yeah. Next question. Why has a single label biomarker for endometriosis been difficult to establish? It occurs only intermittently. Disease is heterogeneous in phenotype, location, and inflammatory activity. Biomarkers cannot enter systemic circulation. Endometriosis cannot produce an inflammatory response. So the answer is very obvious. Correct answer is B. the disease is because of the heterogenic nature, location, and phenotype. Not a single biomarker is suitable. Okay. Next question is, which statement best reflects the current role of biomarkers in diagnosing endometriosis? CA-125 should be used as a popular population screening test. Biomarkers have replaced imaging. No single biomarker currently provides sufficient accuracy to independently diagnose or exclude, and biomarker testing is mandatory before laparoscopy. Correct answer is no single biomarker is currently provides sufficient accuracy to independently diagnose or exclude endometriosis. Next question is, what generally happens to endometriosis after menopause? It invariably progresses. Symptoms often improve due to declining E2 levels. Although disease may persist or recur, it immediately disappears. It should always undergo malignant changes. The correct answer is,
It may undergo malignant changes.
yes. B is the correct answer. So the next question is, persistence or recurrence of endometriosis after menopause is most commonly associated with complete absence of estrogen, continuous estrogen stimulation from endogenous or exogenous sources, increased progesterone production, elevated FSH alone. So also a very easy question. Correct answer is B. Next question. Perimenopausal woman with known endo develops a new or enlarging complex adnexal cell mass. What is the most probable diagnosis? I mean, most important consideration, assume it is a benign endometrioma, ignore if until menopause, evaluate carefully for the possible malignancy, evaluate carefully for possible, I think it is repeated twice, calculate for possible malignancy. So C and D are the same. Yeah. The correct answer is
B and D.
Don't tell. Others are writing. Okay, next. Endometriosis is particularly associated with the increased relative risk of ovarian cancer histotypes. What is the histological type? High-grade serous, mucinous, clear cell, endometrioid, germ cell, stromal, and small cell and squamous. The correct answer is
B.
Yes. Click it is clear cell and endometrioid. Usually high-grade tumors are not as a result of endometriosis. Next question. When considering menopausal HRT in women with previous significant endometriosis, which principle is most appropriate? Previous endometriosis is an absolute contraindication to all hormone therapy. Unopposed estrogen is always preferred. Treatment should be individualized considering residual disease symptoms and potential risk of activation, and hormone therapy eliminates residual endometriosis. The correct answer is treatment should be individualized, considering residual disease. So it is always ideal either to Tibolone will be an ideal choice because only estrogens without progesterone can aggravate the disease. Yes, next. Pregnancies in women with endometriosis have been associated with increased risk of placenta previa, HTP, preterm birth, and all of the above. Very simple.
All of the above.
Don't tell. The answer is yes, Jignesh, you can click the answer. All of the above. Yes, next question. Which placental complication has particularly well described in association with endo? Placenta previa, vasa previa, complete hydatiform chorioangioma. Again, it needs no time to answer. Correct answer is
Mm.
placenta previa. Next question. Which mechanism may contribute to adverse pregnancy outcome in women with endometriosis? Altered endometrial receptivity and residualization, chronic inflammation, abnormal uterine and placental vascular environment, and then all of the above. This is also very easy. The correct answer is
D.
all of the
Above.
above. Next question. Regarding miscarriage in women with endometriosis, which treatment is most appropriate? Endometriosis completely prevents implantation. Some studies demonstrate increased risk of miscarriage, although magnitude of association varies across population studies. Miscarriage occurs only after IVF. Endometriosis protects against early pregnancy loss. A very simple one.
Implantation.
Yeah, the correct answer is they demonstrate increased risk of miscarriage, although magnitude is variable. See, it doesn't prevent implantation because we do come across women having endometriosis becoming pregnant, and miscarriage rate after IVF is increased only when they have associated adenomyosis, and that is not the reason. And endometriosis protects against early pregnancy loss is a wrong answer. Next and the last question is, which statement regarding pregnancy in women with endometriosis is more accurate? All women with endometriosis should be classified as having a high-risk pregnancy solely because of the diagnosis. Endometriosis guarantees an adverse pregnancy outcome. Most women can have successful pregnancies, but awareness of associated obstetric risks is appropriate. Cesarean delivery is mandatory. The correct answer is most women have successful pregnancies, but awareness about associated obstetric risk is a must. So the leader is Nisha. I think the numbers are decreasing day by day. Number of participants. So I think with this, we are coming to the end of the penultimate course webinar series on endometriosis. And I thank all the participants for this program and the speakers also. Thank you so much. Pallavi, can we end?